Good morning, everyone. This is Liz Stanley Salazar. I'm pleased to welcome you all to a very exciting webinar. We had some weather delays. It's raining significantly here in Northern California, and we appreciate your patience. So today, the California Institute for Behavioral Health Solutions is hosting a webinar on confidentiality and the release of information. Victor Kobler, who is our Vice President at CIBHS, will be giving us some instructions on accessing the webinar and how to use the screen. Victor?
All right, thank you, Liz. Well, first off, we have over 320 some people registered for this, so everybody's in listen-only mode. You'll note a question box in the little GoToWebinar control panel on the right-hand side of your screen, and you can type in any questions you may have there, and we'll pause periodically to answer those questions. So I think that's it. The webinar is being recorded, and you'll be able to send a link out to everybody, so if they want to listen to it again, they will be able to do that.
Okay, could we have the next screen, please? First, I want to welcome our webinar participants and presenters, and this is a topic that clearly has tremendous interest. It's been one of the barriers to our work in shared information amongst partners in integrated care. And we are lucky to have Bruce Copley, Director of the Santa Clara County Department of Alcohol and Drug Services, and Dr. Barry Zai, Medical Director and Science Officer in Los Angeles County Substance Abuse Prevention and Control, joining us as our two presenters today. In both counties, they've worked over the past year, maybe 18 months, they'll describe it all to us, in working with their county council, with their partners, with their providers, in developing approaches to authorization that will allow us to provide better care through the sharing of information. Can I have the next slide, please? Okay, the first thing I want to let you know before we dive into the topic is the fact that on the 18th, on Wednesday, the notice of proposed rulemaking for confidentiality of substance use disorder patient records was released and is now in the Federal Register. We will be sending you a copy of the Federal Register. We were not able to load it into the handouts for today's meeting, but we will actually send you a copy of the Register itself as a part of the follow-up to this meeting. The first handout is the announcement, is SAMHSA's announcement. Public relations announcement related to the new rule. It also has links to the public response to the Federal Register. There are changes. Some people would say significant, others would not, but these changes will allow the use of universal authorization between entities, and that's the significant change for us in the field. So with that, I will turn this over to Bruce to take us through the presentation. One last thing, though. I would say that there will be 3 poll questions during the presentation, and we ask you to participate in these poll questions to give our panelists a sense of where your county is at or where your organization is at in the use of confidentiality release authorizations. So with that, I'll turn this over to Bruce.
Good morning, everyone. It's a pleasure to be here. I'm very excited for the interest that you're sharing in terms of confidentiality. Within our realm with 42 CFR, over the years, there's been an anxiety about breaching the regulations, and with the development of integrated health care over the last years and with ACA, it's most definitely become an issue as the health system tries to coordinate care between primary care and our substance use services. in Santa Clara County, we actually looked at releases of information about 20 years ago when we started the drug treatment court, and we looked for a way that we could work within the drug treatment court setting, provide information that didn't in any way jeopardize 42 CFR, but provided the courts with information related to the experience that their defendants were having within treatment. And so we developed, through our county council, a blanket release of information, which you'll be able to see later. And that was really the start of looking at how we could bridge the divide of 42 CFR and discussing meaningful treatment issues with the court system. As I say, with the move to whole person care and the emphasis on coordinated behavioral health services, with the ODS waiver and the requirement that counties that opt in have MOUs with their health entities, there is a growing pressure to be able to exchange patient information both within the health system towards primary care as well as primary care towards substance use. Along with that is the understanding that chronic health conditions are associated with behavioral health, and there needs to be a coordinated recovery plan to address chronic health conditions. There's a growing understanding in the nation that much of the chronic health issues have some relationship with substance use or have a component of denial that requires the individual with chronic health conditions to begin to manage their own health issues, and the use of motivational interviewing and the techniques the recovery system has used for years are very applicable for that. And finally, with the current 1115 waiver, the bridge to reform, with what it appears CS is interested in, at least in the dialogue we have had with them around our waiver application, it's very likely that in the next waiver in 2020, there will either be a full integration of behavioral health and physical health, or a greater connection than there is now. And again, it will bring up the issue of how do we share meaningful client information necessary for the comprehensive care of the individuals. Next slide. So we all understand HIPAA on the mental health side, the required patient consent. With HIPAA, there are broad exceptions within the rule for patient information exchange. There is the emphasis of being able to exchange information. Most definitely where there are billing issues, we're able to provide information in terms of client care. And where we're looking at quality improvement and outcome measures, we're able to share information. The only exception is with psychotherapy notes that without the express authorization of the client, we're not able to release those. But under the HIPAA context, and that is both within mental health and more familiar with the healthcare system, there is a information is much easier exchange. And so we're always up against the entities that understand HIPAA, and then when we tell them 42 CFR that we can't release information, there is that consternation. Next. So at this slide, I'm just trying to give kind of the salient points to what 42 CFR talks about. It applies to all health organizations that receive federal funds, federal tax benefits, and providers of license under Medicare. So essentially, it's our entire system and any of the system components that touch us. Anybody that receives information that is exchanged under 42 CFR, they're required to follow all re-release requirements within the 42 CFR, and that's an important element when I share with you some of what we've done with our healthcare system. And of course, there are no exceptions for the use of patient information for quality improvement purposes in a court, unless you have this blanket court information release. It requires a court order, and the court needs to weigh the 42 CFR regulations versus the need to know. and often, in my experience, courts will not ask for the release. They abide by 42 CFR. Next. So this is the first question. This is we really want to get. Oh, I'm sorry. Did you want me to?
I would. Let's do the poll, Bruce, but then let's go back and talk through the handout. Handout number 3.
Number 3.
The actual, which is actually criminal justice.
Okay.
Let's go ahead and do the poll at this point. So at this juncture, we would ask everyone to take a look at your screen and simply check on one of these poll numbers. It will take a few seconds to see how people are responding. And the question is, how frequently do your SUD providers share information with the physical and mental health providers now? Are we getting responses to the poll? Is it working? Yes, we are beginning to see responses to the poll, and we will leave this go on for a few more minutes as everyone takes an opportunity to respond. Okay, there we go. One more second or so and we'll close the poll. But Bruce, is this the experience that you're having in your county in terms of what Santa Clara has done, or is your experience different than the general audience here on today's call?
Yeah, we have a much higher very frequently relationship. Again, that has much to do with the work we've done over the years with criminal justice, but it's very frequent. I'd say probably 50-60% is very, and the rest is sometimes. We have very few incidences where we're not sharing information where there are co-occurring issues.
So your experience then is driven by your partnership and the maturity of your system, and I'm drawing the assumption then that you're noodling the release question and coming up with authorizations, which you're going to share with us now, were critical to the success of the communication.
Yeah, again, because of the anxiety produced by 42 CFR, the documents and instruments we developed helped allay those fears and the reticence of sharing information.
Okay. Now, you mentioned criminal justice, and you are going to speak to physical health and your relationship with physical health and mental health providers. Is your experience, has that been historically different than your criminal justice history, or is that the same, that you've had a high communication level between physical and mental health, or maybe different between the two?
It happened about, I mean, over the years we realized the need to be able to talk with primary health care. About 4 years ago, and kind of preceding ACA, but realizing just how much of our population was also being seen by our county health system, we began to discuss how we might have a easier way to share information. So at that time, and I actually got our county council to develop an MOU with our primary ambulatory care health and hospital system, and it requires all 5,500 health professionals that work on that side of the house to take 42 CFR training annually. It's part of the mandated training that all of the health professionals have. So it has, I mean, that alone has freed up the ability to share information with their understanding and obligation that they can't re-release without abiding by 42 CFR. So that's kind of the framework that later on you'll see the new release that were developed.
Okay, with that, that's a great segue into now doing a bit of a deep dive into each release.
Okay, so
for folks on the phone, let me just give some instructions here. You have the handout. You can open them on your computer, the forms themselves. You can open them on your computer, or you can print them. And Bruce will not show them on the screen, but speak to them in addition to the slides. So let's start with the criminal justice release.
Okay, and the genesis of this was happened when we 20 years ago developed our managed system of care. Prior to that, as I think many counties I'm aware of still have an issue with, you had courts mandating a specific level of care, primarily residential, and trying to establish mandated times within residential. So when we developed the managed care system, we met with the court and to help them understand that the placement of an individual in treatment was a clinical issue, that was not something that the court could mandate, that we would provide the information in terms of what we believed the individual needed in the way of treatment, whether that was residential or some level of outpatient, and that we would then allow that individual to agree or disagree at the court with the placement. Once within our system, it was understood that that individual, whether they're in residential or outpatient or in residential, that they would move into an outpatient setting at the time that they were stable, not, again, based on any set time that the court ordered. So to get that relationship started, we needed to ensure the court that we could provide them relevant information to the defendant's case. And so that's what we went through this first release with. It had all of the criminal justice players that are part of the court on it. It allowed the defendant to sign it. It was very specific in terms of what information we would release. Along with that, I proposed, and it was accepted by the court, that we would do a monthly treatment status report. And that would be the way in which the court could monitor the individual in treatment. It would not specify what was happening in the specific treatment, but it would say the individual is meeting objective goals. They're within the treatment provisions of their recovery plan. So it was a high-level way that the court could understand what was going on without beginning to get into clinical issues that we wanted to keep within our house. And then finally, everybody that was in the court understood that this information was again under 42 CFR, and it could not be re-released without meeting the 42 CFR guidelines. That's been in place for the last 20 years. It's been used by both treatment court judges as well as the other judges that come on board. Oftentimes you'll get a new judge in and they have their own version of what they're going to do in their court, and oftentimes they get into mandating a certain component of treatment, and it is something we have to discuss with them. But again, with this release, they feel that they're going to get the information necessary to monitor the case within their court.
Very good. And you mentioned at the beginning, I'll ask a question now, you mentioned at the beginning of your discussion of your partnership with the court system and criminal justice that they initially, the judges felt, or maybe the other court personnel, would make recommendations for treatment that were not clinically based. They were probably more public safety oriented. Has this process that you've put in place in this release form mitigated that? Yes,
that has not been that has not been an issue for years. So it's a healthy partnership between the treatment court and the recovery system.
Wonderful. So let's move on to the next slide. Are you ready for that?
Sure.
Oh, no, I'm sorry. We're at the back up. There we go. We're at the Santa Clara Valley. Yes.
Next one.
Next slide. Santa Clara County Hospital and Patient
Right.
Form. Again, I'll just draw everyone's attention, Bruce, to you have this form, folks. You not only have the form in handout number 4, but you have the entire policy and procedure county notice with the form. And so the policy and procedure is the front pages of that document, and then the form itself is within the document. Okay.
So what audience? What you have now is the new iteration of a release that will be used throughout the health and hospital system. You'll see that it cites all of the relevant PHI statutes and regulations. It will be used both from the recovery side as well as within primary care. And again, it moves us towards that coordinated system of patient information exchange that is important in the development of a comprehensive recovery and treatment plan, both from the health perspective with the chronic health condition and from the recovery or mental health setting. It has been worked out with the county councils that are both the Behavioral Health County Councils and the Health and Hospital Council. And in many ways, it is kind of the next step with what Liz talked about in the changes to 42 CFR about being able to exchange health information that is necessary for the proper care of an individual. It moves us towards that seamless area in which we can exchange patient information that is both useful from the primary care side as well as from the recovery substance use side.
I'm looking right now if we have any questions. I'll come back to this. Please, I encourage you to take advantage of this opportunity to ask questions of Bruce. We do not have any in the question box at this moment, but I have a couple of questions that that have come to my mind. It sounds to me in both situations, you mentioned the fact that you're providing extensive training. I do have some questions, but you're providing training to medical personnel throughout the county on 42 CFR and on how it interplays with HIPAA as you roll out this document. Did you do the same in the criminal justice system? Do you provide training, and who does that training, both for criminal justice system if you're doing it and for the healthcare providers?
Yeah, so up until a year ago, we actually had staff that would do it on a regular basis for our partners. What we've moved to is an e-learning module that is available to all county personnel, and it surely will be available to all of our community providers. So they'll be able to access that training along with some other trainings on the e-learning module. And then we will, in our annual evaluations and review of programs, ensure that all of their staff have updated learning modules for that.
Excellent. Is there a particular vendor you're using in the county for your e-learning, or is that a county system?
It's a local growing module, and we actually develop with our staff. We develop the questions and answers for it.
Excellent. I do have a few questions coming in now. Here's the first one. Does Santa Clara County have ASAM level 3, 7, or 4 that you are currently using and this form for?
Well, the form will be applicable. We have yet to, no, we definitely are looking at 3.7 and 4. We're in some tentative discussions with our health system, and this new release will lend itself to that exchange of information. So that's we're looking to do that in the second year of the waiver.
Here's a question that's coming in. We have quite a few coming in now. Are these forms used by Santa Clara County only at this point?
They're used by both the county side of the house as well as all our community providers that have contract with us.
And then another question related to EHR. Which EHR system does the county use? And are both mental health and SUD providers using the EHR?
So currently we're on what was called Unicare. We're in the middle of exploring on the county side of the house to move to the Epic system. And we are involved in a negotiation for an intermediary program that will link the Epic information and the community provider information in order for billing and state reporting, a practice management module. Each of our community providers are on their own EHR but are required to have bidirectional ability to exchange information with the department.
Okay. It's fairly clear. Up here, can some more. Is a county, I mean, this would be an opinion on your part, is a county allowed to customize these forms, and how would you suggest someone go about customizing them and using them in their own county?
Well, they're all of they're not copyrighted. They're public domain. So you all in each of your county can look at it, decide what, if any of it, is reflects where you want to go, and use it to your heart's content.
Okay. There's a question here. We're still on time. I'm tracking the time. A couple more questions that are coming in from counties. And what's been your experience sharing PHI between call center and access line, and to the providers to which the callers are referred?
Well, we have on our side, the gateway side, which is our 1-800 call center that receives, it's the only way into our substance use system, and many of your counties know that. So our provider, our call center staff take the information, and then we actually do warm handoffs. We connect them to providers. We ask them, is it all right to share your interest in receiving treatment? And County Council has said that is acceptable as a way to release information. So again, it's not an issue with how our County Council has seen the need to connect people to treatment. It's all part of that network required to link people with appropriate treatment. The next question is, in your system, in your use of EHRs, have you taken your releases, and are these documents embedded in your electronic system? Are they PDFs, or are they embedded? Yeah. So right now
they're. What's your plan?
Well, with where we're going with the EHR, yes, they will be embedded in an electronic file. Right now, they're paper file, and they're faxed on secure fax lines. But once we have evolved the EHR and the practice management module, those, along with many of our other forms, will all be e-file.
Okay. There is another question about your EHR. There's several questions about your EHR, but one of them that's most interesting is, well, one, what is your EHR that you are using? What's your vendor? And so you may want to answer that one first.
Yeah, it's Unicare.
Okay.
They're throughout the country. They're not big in LA and California, but they're in Oregon, Washington, and many of the eastern states.
Okay. And then what types of metrics, once you embed this and in your electronic health record, what kind of metrics do you plan to use, and will you be able to track the end dates of disclosures and get a trigger or a notice that the disclosure has needs to be renewed?
Yeah, so I mean, most of the EHRs that I'm aware of have date flags. So it's simply using the date flag function that each EHRs have for treatment plans and for other documents that need to be reviewed and updated regularly. In terms of the metric, I mean, we would rely on our providers to maintain that information. That's all part of the contract that we have, and that they do an attestation every year within the contract review that talks about this, and along with a number of other regulatory components that we ask them to do.
Okay. A couple other questions, and then we'll end on just maybe two more questions. Folks are very interested in how you are interfacing with mental health with the side of the house. Are you facing any challenges in terms of mental health having their own forms or requirements for confidentiality versus your forms? Are these going to be universal? What are the challenges you're facing with interfacing with mental health?
So the second form that I shared with the audience is going to be used by mental health. So we'll all be under the same uniform form and abiding by the policy that is attached.
Wonderful.
And again, at the moment, if mental health needs information, they get a release, and we make the exchange. It hasn't been a problem. I mean, it's a piece of paper, but it hasn't been a problem to actually have that information exchanged.
Okay. This is another interesting question that I know you've raised in several forums, the question of how do you manage episodes within the system itself. How will the authorization be applied to movement between different episodes?
Well, again, I'm fighting with the state to get CalOMS to become an episodic-based system that allows individuals to move freely up and down in a continuum based on their needs without having to open and close. And at least I'm getting some traction. Currently, it would require, if we move somebody, close somebody, and we open them, the release would say we're exchanging information to your next level of care. Within a organized delivery system, as we see it, once there's a release, then that is good for the duration of the episode and for the providers that are serving that individual. Very similar to what happens on the primary health side of the house. If you move from your physician, your outpatient physician, to a specialist, you don't have to keep re-releasing you. That's all part of the episodic care. So that's what we're pushing, and any other county that wants to raise that banner with us, please do so, because the current system makes no sense having all this open and closure. It totally eliminates the ability to track the success of care, because you show no continuum, and you can't really track what's going on from the beginning to the end.
I think that we have several more questions, but we're going to have to move on, and these questions are getting very detailed. So what I would suggest that we do, we're actually getting into acronym speak. What I would suggest we do is we'll have all these questions, and we will attempt to circulate answers to them within the next 2 weeks of the training. Questions are also being asked, are we going to distribute the slides? Yes, the slides and all the handouts are going to be available, as well as a recording of the webinar. One of the things I want to note, my takeaway, Bruce, I just want to comment it as a closing remark before we move to the next poll. What's really wonderful is the maturity of your system and that you've been working on this for so many years. But it's not just about creating a release form that individuals can use. This is embedded in a system, and what was most interesting to me was that you not only created the consensus among your partners for the use of the form, you have an embedded training process so that all new staff and new partners are receiving the same information at the same time within your county systems. And you also have defined how the information, you spoke to this when you were talking about the criminal justice piece and those releases, that you have a very defined way of this is what the monthly report will be. There's a standardization. You have systematized all of these actions rather than having it be a case managed on an individual basis by an individual case manager. You've worked through the details of this. So I think this is a great model to use.
Yeah, I think that's a good synopsis, Liz.
All right. So thank you so much, Bruce. Let's move on
Sure.
to our next. Poll. And audience, if you would take a look at this next poll and just give us a quick answer. Do you imagine making changes to your release forms or consent management processes as a result of the DMC waiver? All right. Should we go ahead and close this poll, see what we've got going on here? Yes, here we are. So here's the poll answers. You can see from the poll that the majority of the counties are working on the changes to their current releases of information. We have 30% who are not sure, and maybe this webinar and the new confidentiality regulations and the samples and examples here will assist you in helping make that decision as to what you can do with your releases. With that, let's move on to the presentation by Dr. Sy.
Good morning. Thank you, Liz. Thank you, Bruce. Very happy to be here this morning speaking about this issue. I share Bruce's excitement about this topic. It's funny, generally confidentiality is not the most enthralling of topics in healthcare, but I think that in the addiction field, because of how siloed we've been, some of which is very appropriate and necessary, and others which have made, I think, care integration challenging. The issue of release of information and confidentiality, I think, is central to us achieving our goal of mainstreaming substance use treatment into the rest of healthcare. And so this is a very important, I think, topic. So the next slide, I wanted today to provide a framework for developing release of information or consent forms, or at least describe the process that we undertook in Los Angeles County, and also provide a framework for working through change, really, and how to address challenges that may arise because of that change. And so I'll be going over kind of the opportunity in front of us, some of the challenges, some of the things that we did to address some of the challenges that we came across, specifically using our consent forms and going through key areas of the consent forms, and then lastly a summary. Next slide, please. And so, the opportunity, and for the counties that are opting into the drug Medi-Cal waiver, or even making changes in their release forms as a result of some of the care integration needs that are widely recognized now, I see us as that lone goldfish, jumping into the next opportunity. And it's a very exciting time, but also can be a bit scary. So I think there are a number of opportunities that are aligning well to help us achieve our goal of better care integration and eliminating the siloing of substance use treatment. Can you please go back to the last slide? And so some of these opportunities are the drug Medi-Cal waiver, the parity requirements, the fact that addiction medicine is now an officially recognized medical subspecialty, which should bring in a crop of new addiction physicians and prescribers in terms of medication-assisted treatment. And then lastly, the fact that addiction clearly is now a national priority, given a recent Surgeon General's report on addiction, the first, I believe, ever written by a Surgeon General, as well as the opioid epidemic, which is often highlighted in the media. Next slide, please. And so I think it's important to start out by defining what our goals are. And so, in Los Angeles, there was work that began, well before my arrival, to develop a universal release form. The goal of this was to facilitate information sharing between county or contract substance use providers and those outside of our substance use network of care. So those entities would be health plans, the Department of Mental Health, because in Los Angeles, as some of you may know, we're not folded under one behavioral health system. Our substance use services are under the Department of Public Health, and the specialty mental health is under the Department of Mental Health, as well as the Department of Health Services. And so the ability to share information across those systems. The other goal that we had was to develop a more standardized release form that was used within our network. So, we call this intra-system information sharing. The benefit of standardizing the release would be to better facilitate information exchange between substance use providers in instances where people are used to seeing their version of forms. And then I think the main benefit is to move us towards a health landscape where people can exchange substance use information freely and openly, assuming that the appropriate consents are obtained. And so this would involve providing clients an option to consent to share information with a network of providers, as opposed to only specifying individual providers. While they also still have the option of consenting to share information via the more traditional method, I think that most substance use providers are familiar with already. Next slide. And so the challenges before us, next slide, some of the things that we came across as we were working through this, which I think many on this webinar will be very familiar with, were kind of the culture of information sharing within the addiction field, kind of a no culture in terms of our first response to requests for information being no, and some of this is related to individual, perhaps over-interpretations of what 42 CFR Part 2 requires and doesn't require. And then I think more generally speaking, a resistance towards change, which I think we can all acknowledge is difficult. And when we're used to operating in an environment where we place substance use information into a silo or a box, and that information is essentially walled off from all other health information, it's difficult to open that up. And so I think that's the process that we have and the challenge that we have in front of us. Another challenge has been varied interpretations of 42 CFR Part 2, whether it's with your county council or whether it's with the legal councils of your providers. I think that this challenge differs if your system provides solely county-operated services versus a system that's primarily contracted out. In Los Angeles, we're primarily contracted out. And so what that means is that not only did we need our consent forms to go through county council, but we also need, to a certain extent, buy-in from the legal counsels of our providers, which has been challenging at times. And then lastly, something that I think we had touched on earlier, technology. In substance use or behavioral health systems using electronic health record or EHR, those EHRs need to be 42 CFR Part 2 compliant, which means that the data has to be segmented in certain ways, and there also has to be a consent management system in order to facilitate those communications. Next slide.
At this point, we're doing a third poll, our third and final poll, and so we will ask you to take a few minutes. We'll give you time so that we do get, we're very interested in the answers, so we're going to give probably 3 minutes here to everyone to make sure you get in and take the poll. And so the question at hand is, do you have an infrastructure? A technology infrastructure, an EHR with a consent management system embedded in it to facilitate electronic exchanges of information. Okay. People were quick on that one. So as you can see, it's divided into thirds. The 30%, 35% of the counties already have the technology infrastructure. Another third do not have the infrastructure, and a third are unsure. Before we move off of this question, since we're here and or this issue, and the next element will be moving into the releases themselves, Gary, can you comment on maybe the steps to even engaging your technology office or information, your specialist, your IT specialist in your county in this issue? Were there any special steps you took or communication that had to be taken to activate this integration into your technology, or are they planned?
I think that really depends on the level of knowledge that your IT departments may have in these various confidentiality rules and regulations. I think most of the time that they're quite knowledgeable, given that they have to operate in this space, and so that was the case for our IT department. If you're working with a vendor, generally, they're already very well aware of 42 CFR Part 2 requirements if they're used for substance use, and they're already baked into their product. That said, I think that the framework that I tried to outline today applies to everyone, including IT departments, if there are instances where people don't quite understand why we're making the changes that we are. So yeah,
Okay.
I think it's very.
And I'll ask a specific question that came in on this. Have you been able to structure your system to address all of the consent issues at this point in time, especially issues that have to do with revoking the consent?
Yeah, I think that's a very important question. That's perhaps one of the most complicated aspects of at least a universal consent, if that's available in your respective counties. Currently, we're in the process of acquiring an EHR for the substance use system, and so we're working through that process. That said, one of the key areas that we've needed to work through is what kind of consent management system is in that EHR, and also in particular, how we're going to operationalize the universal consent form. One of the challenges around universal consent forms is that given the intention is to involve a lot of different parties, that also means that the ability to revoke that consent also applies to those involved parties. And so it's possible that, a client will show up at the health plan level and want to, revoke consent there, or might show up to a substance use provider or a mental health provider, and there has to be a system in place in order to notify others when that consent has been revoked, as well as to manage the expiration period that's generally accompanied with that release of information. In our case, it was a year. But the consent management aspect of this is very challenging and made much easier if you can leverage the technology available to help you with that process.
Another question that came in, how are you planning on segmenting SUD and primary care records in your electronic medical records? How are you going to create firewalls?
Yeah, I think this depends on how your system is structured. So if you're using a system such as Epic that Bruce had mentioned previously, there's likely going to be physical health, I'm assuming there's mental health records on there, and then, it sounds like Santa Clara is merging substance use on there as well. The EHR vendor, Epic, would know how to firewall that. So that's more of a technical issue, at least from my perspective. In our case, we're in the process of acquiring an SUD-specific EHR system, and so it will, already be segmented from other information. But within that EHR system, you also have to segment by agency. That's one of the data segmentation requirements of 42 CFR Part 2. And again, that's more of a technical issue that your IT folks as well as your vendor should be familiar with.
There's several questions that have come in about the interface between mental health, EHR, and SUD. You answered it partially and letting folks know that you are purchasing and developing a SUD discrete system, and that implies that you might want to comment on this, mental health organization has a separate EHR. How do you differentiate, and what are some of your comments on how the partnership will work in terms of sharing data between mental health and SUD?
Yeah, so our substance use EHR, won't necessarily be different. I mean, it may be the same, but I think that the information that's shared between them is governed by the consents or the release of information in place. Assuming that those consents are in place, then given that any certified EHR, I believe that all counties are using certified EHRs by requirement, they need to be interoperable, which means that there need to be ways for them to exchange information, which is again a technical issue using, I believe there's CCDA documentation and HL7 methods of sharing that information. But that's what the consent management is designed to do. Basically, the user can specify whether consent is or is not in place, and then the consent management system can direct when information can and cannot be shared and between whom it can be shared.
Okay, let's move on.
I would.
Go ahead.
Just a quick comment. To really better understand how the information flows in conjunction with the consents that we're managing, I would really encourage a close partnership between the your clinicians or your staff with your IT department as well as your EHR vendor in order to really better understand that information exchange. So moving on, this is the third part of the presentation. So we've talked about the opportunity, we've talked about some of the challenges. Lastly is, how do we work through some of these challenges? So a little bit about problem solving. Next slide, please. And so, I really like to think about these solutions as how do we align the opportunity that we have with the challenges that are apparent. in the minds of those who these changes most closely impact. And so a big part of that is how we present this to our stakeholders, which includes our staff, our providers, and also the clients that we're serving. And so to providers and staff, I think one of the early tasks that we had was to clearly articulate a vision as well as a goal for why information exchange is important, why we need to make some of the changes that we're envisioning and that I think have been supported by the recent changes to the 42 CFR Part 2 regulations. And also, how do we get buy-in from the frontline providers? Because when it comes down to it, those frontline providers are the ones who are actually obtaining the consent, and if they don't buy into what we're trying to achieve at a system level, or even at a clinic level, then it's going to be really difficult, I think, for us to achieve our end goal. And so talking to key provider groups or champions to build this case, I think, can be very helpful. At the client level, how we ask clients for this consent or for this release of information is really important. And I've outlined kind of two ways to approach it here. One is we could approach it very succinctly. Do you want to allow us to share your drug use with other health providers? And I think the framing is important, right? The words that we use. So do you want us to share your drug use? And so I think that an important part of this is how we engage with clients to discuss information sharing. And the alternative that we could do is to better contextualize, why we want to share that information, acknowledge some of the challenges and some of the risks with sharing that information, and then really having a in-depth conversation about how the individual feels about this and, if they have any questions. And so I won't read through, the other example about how we might better contextualize that. But I think that when we're serving a population that we're serving where there's either resistance or denial to information sharing, this contextualization is really important. And this comes from my experience working in the inpatient and emergency psychiatric settings, where we're dealing with oftentimes families who desperately want information about the health and well-being of their loved ones. And we're in a position where we have to consent individuals, sometimes who are very severely mentally ill, about sharing that information that they oftentimes have reservations about. And I think that through that process, you learn that every single word that we use in that interaction, the tone, our body language, I think impacts the response of the client, and often their decision about if sharing information is something they want to agree with or something that they don't. And so, for me, it's not about making the decision for the client or kind of artificially, being manipulative, but it is about explaining, why we want to share the information, why it's important, how it can improve care, and also talking about some of the risks and being able to talk through any concerns that the client may have. Next slide, please. Another area that we needed to resolve was the varied interpretations of 42 CFR Part 2, as I had mentioned previously. As with any law or regulation, there's a lot of subjectivity that can be interpreted into the language of the law. And, as I think many of us know, 42 CFR is not entirely black and white. Even something as simple as, if someone is federally assisted or not, which is probably one of the more black or white aspects of 42 CFR, there have been different interpretations of that. And so because of that, I think that interpretation should be leveraged to the advantage and the benefit of the client or the patient, which oftentimes also advantages the system. And so the same way that I think it's important to contextualize the importance of information exchange to clients, I think it's also important to contextualize to the various legal counsels, the counsels that are involved, why 42 CFR exists, why we're wanting to share information in ways that we haven't in the past, what's the goal, and also, what are some of the concerns in doing so. And I think having this conversation and providing this background to our county council in the beginning, particularly when we were establishing our standardized release form, was very helpful because we were able to then partner with the county council who understood what our goals were and could help us achieve that within the legal framework that they know that we need to abide by in terms of the regulations. And then, lastly, something that just recently occurred in terms of the final rules of 42 CFR, has been helpful as well in terms of clarifying. So one of the issues that we ran into in our consent form was that our county councils, as well as the health plan councils, all felt that it would be appropriate to consent to a larger entity in the case of our universal consent form, as opposed to specifically specifying the treatment provider. And the universal consent form was years in the making. And so this was prior to, obviously, the final rules being released last week. And so in a way that interpretation was different than what people were used to, but given our communication and our work together, that was the legal counsel, our county council's interpretation. Now that the final rules are in place and they specify specifically that entities can be consented as opposed to individual agencies or providers, that helps move us forward, I think, in terms of being able to share information, particularly in the format of a universal release. And then I think the other highlight of the recent rules I just wanted to mention is the modernization of the 42 CFR regulations to accommodate technology. So specifically EHRs, or health information exchanges, specifically addressing the ability to sign things electronically if you have that technology available, and just to allow for more leveraging of technology in order to help facilitate this information exchange. Next slide, please. And then the last part of the solution development is really, how do we assess and address the concerns that have been expressed, whether it's the legal counsel that you're speaking with, your providers, your staff, the clients that we treat, or other stakeholders around the county. And I think a big part of this was the communication that I emphasized previously in terms of painting a picture of the vision and the goals, really understanding specifically what some of the reservations were, and I'll go through some of this when we go through the consent forms around the particular areas that some of our providers had expressed concern about and how we went about addressing that. And also just realizing that this is a cultural change within our field, and that with any cultural change, it takes time, it takes persistence, and that I think we need to acknowledge that incremental changes are still wins, and that we may not be able to achieve our end goal in one foul swoop, but that it may take some time. While that has been frustrating at times, I think that it's also been important in terms of maintaining our collective sanity. Next slide, please. And so here I wanted to go through some of the specific forms that I was referencing previously. So handouts 5 and 6 are the handouts that are our universal release form, and then the standardized disclosure form that I referenced previously. And so starting out with the universal release form, and again, the purpose of this was inter-system information exchange, so between systems. So the first section that I think was a change was section 1, where the user specifies the entities who may share this information. And so you can see on the document that the various health plans in Los Angeles were included here: Department of Health Services, Department of Mental Health, Public Health, which is where substance use, the administration of substance use resides, as well as the Department of HIV and STD programs. And so basically the user is able to specify an entity. And with the final rules changes as referenced previously, this clearly now is an ability for us, it is a capability for us to leverage in exchanging information across systems. But when we initially presented this to our provider network, there was a lot of discussion about how their legal counsels would not accept this, that this was inconsistent with their understanding of 42 CFR Part 2. And so, we had to make certain changes as a result to address that. And so one of the main changes that we made was in the addendum that you can see at the very back of the on the 5th page of this universal release form. We essentially created a separate addendum that our substance use providers could use in order to specify specifically which providers would be exchanging this information. And they could do so through the list of providers that are included here by circling it off, or writing in other health providers who they might want to exchange information with. Now that the final rules are released, I think we can have discussions about if this addendum is still necessary, given that the rule clearly specifies that entities can exchange information if it's appropriately consented for. But in terms of problem solving, this is our way to address some of the reservations that were expressed by a provider network. The other area for the universal release form that there was some talk and concern about was around the revocation of authorization. And so you can see that on the 3rd page, it specifies that at any point someone could revoke this authorization. And this is something that I think is still being worked out in terms of that consent management process across systems, and how we're going to use technology or perhaps do things manually in the beginning until that technology is available, in order to ensure that wherever an individual revokes the consent, that all other parties who are involved are notified. And so, in a lot of ways, it's still a work in progress. But working through where the universal release form will reside, so who is the primary holder of that. In some instances, it may make more sense at the health plan level. In others, it might make more sense at the county level. I think it will be, an individual county decision about that will be important, as well as working through the workflow of who needs to be notified when revocations occur. I think it's also important to note that in the experience of, I think, a lot of our providers, revocations are not common, and this may be the experience in other counties as well. And so it's not that this necessarily will occur all the time, but it is the case that we need to have some mechanism to ensure that revocations are appropriately dealt with. So that was the universal release form. I'm going to move over to the system-wide release form that I referenced previously, and so this is, I believe, the 6th handout. I think this form will be familiar to many of you. I mean, it looks fairly similar to the standardized 42 CFR compliant documents or consents that other systems use. I think one of the biggest areas of change is in Section 2, where the user specifies who they want to consent with. And so, as I mentioned earlier in the presentation, we really wanted the clients to be able to consent to all providers within the network, should that be what they want. Because there are clients out there who, are not particularly concerned about the sharing information amongst health providers, including substance use, and will willingly agree to this. In other cases, there's going to be, this might be the majority of individuals who want to make sure that the information being shared is more controlled, and that they have more control over that, in which case there's still an option for them to specify specifically, who is sharing that information. And so this release of information essentially gives the client 2 options, either to share with everyone within the network, or to share specifically with providers, as is more traditionally done. I think that with the recent rules changes, we have an opportunity to re-explore this and see, how we want to approach the fact that entities can be consented as opposed to individuals. The same addendum that was applied to the universal release form was also applied to this consent form to address the same concerns around needing to specify individual providers. Next slide, please. And so, with that, the summary is, I think, just a summary of the framework. In identifying goals and clearly articulating vision, I think, is really important. Obviously, identifying what some of the concerns or challenges are, acknowledging that cultural resistance, legal interpretation, or technology might be areas of particular difficulty in counties, from our experience at least. And then lastly, how we address those concerns in terms of, creating creative problem solving, such as the addendum that I mentioned previously, or also how we talk with individuals about, what the vision of these changes is. So with that, I think I'll close there, and if there are any questions, happy to answer.
There's a couple of questions here, some more specific than others. What I want to acknowledge is we will accept questions both for Gary and for Bruce. We'll also comment if he has any thoughts about this. I want to recognize that the difference in the two counties. One is a county, Santa Clara, that has developed a organized system of care over many years in a very deliberate, centralized, and uniform manner, and the development of policy and procedure related to, and practice related to consent has been developing and maturing over many years. LA undertook this within the specific guidelines of the waiver, and so it is newer at the effort, and yet, as you can see from these consents, has made significant deliberate movement forward on the issue. I would ask, it's clear, Bruce released his policy and procedure, and you're referring to still building a consensus about the actual policy procedure and specifics of practice and workflow within that across the county. What's your time frame on the development of that, and will it be made available to other counties?
We're still working. Yeah, we're still working through the operationalization of that universal release form. It does involve a number of different entities, including all the health departments, county health departments, as well as the health plans. And so it is taking some time, and there are a number of meetings that have been scheduled to address this. So I don't have a clear time frame, to provide right now. I would say that I think all parties want to get this finalized as soon as possible. When it is finalized, I can talk with our other county partners and see if it's fine sharing. I don't see why it wouldn't be, but I would just want to clear it with them.
Okay. One of the questions that came up, and you spoke to it somewhat, but what if clients do refuse to, agree to the release of information? What guidance will you provide providers in managing or handling that situation in either county?
Well, this is Bruce. Again, that comes up most often around the criminal justice. We abide by the client's request and advise the court that we're unable to provide information at this time. And again, because of the length of time we've had this, it doesn't happen often, but when it happens, the court needs to decide what they want to do with it. We obviously continue to treat the individual, but we hold the line to abide by 42 CFR regulations.
Okay.
Yeah, I agree. I mean, this is obviously purely client and patient preference, and so it's really their decision what information they wanted to allow us to share. That said, I do think that at the frontline provider level, part of their job, our job, is to steer people in the direction that we think would provide them the best care. And part of that involves thinking through very deliberately how we communicate around this issue of information sharing with patients.
There's some specific questions related to your criminal justice release, Bruce. And
yes.
There's a statement that, it's very specific question, in talking about, however, a person, quoting right from the form, however, a person, and then, appears to leave, this whole statement, this is fairly wide open and leaves a window of opportunity for the court program participant to release the information. The questioner is curious about how was this discussion during the creation of this form? How did that discussion go on between the public safety, the court, and your division?
Well, again, one of the desirable processes there, we have Judge Manley, who is an advocate for treatment. So it was sitting down and explaining, what our obligation was under 42 CFR, what our obligation as a health entity is to meet the request of the client in terms of release information. And I mean, where there might have been glitches along the way, we sat down and looked at it. Both the court and our department had, as Gary said, had the vision that we wanted to embrace 42 CFR in treatment and not step over the line and lose that ability to have a treatment alliance with our clients versus what the court needed from a defendant.
Okay. Here's a new question. There's a couple of them related to the same thing, and it has to do with qualified service organizations. What have you been discussing in each of your counties related to the use of qualified service agreements? Where would you use them, and what are the limitations of qualified service agreements?
Well, again, I mean, that was one of in the comments to the feds. That was something that Santa Clara County talked about, wanting to open up to have the feds see that the health entity, the integrated health entity, served as a qualified service organization. I still think we need to press that. Again, as I said, with what probably or could happen in terms of further integration of healthcare in the next waiver, it will certainly come up again. And again, within our county, the release information form we developed is trying to get towards that concept, but it's not clearly there yet.
There's quite a few questions about revocations and redisclosure, and so this is an area, obviously, that challenges us. Gary, you spoke to it. Bruce, you also spoke to it. Any final words on revocation and redisclosure and how you'll manage it in your individual counties?
Well, again, if it happens, if there is a breach, our compliance officer gets involved and we do a root cause analysis. So in those episodes, we get with the provider and work through why that happened and how it won't happen again. So it is a very rare issue at this point, but we sit down and have every party at the table and explain what is legal and what isn't legal, and where was the breach happening, and how do we stop it from happening again.
So what I'm interpreting from that is that you clearly have a quality assurance or monitoring process built into your process, and you do follow-up, and the data so far is telling you that your system is working.
Yes, yeah, it's a rare episode in which we have any kind of a breach that we have to take control of.
With respect to revocation for universal consents for counties that are exploring that, one of the things that we've talked about is the importance of having a single universal consent. And so I think that in that respect, training across the different entities that are part of that universal consent is really important in terms of, if you have a situation where the Department of Mental Health consents someone using that universal release, and then one of our substance use consents someone, several months later, you essentially have two consents with different expiration dates, and also, the revocation can get complicated. At the frontline level, the tendency is going to be, well, I need to consent someone, so I'm just going to pull this form and have you sign it real quick. As opposed to with something like the universal release form, you really want them to go to the universal release form that's been signed or check to see if it's been signed elsewhere prior to doing that in order to limit some of the complications. And so thinking through the workflow and the process is just really important.
Yeah, I support what Gary said, and that's why we went to this one form. I mean, in the past, the juvenile system had a consent, social service had a consent. Is pulling all, getting rid of those, and coming up with one, and again to try to establish a structure to where you can control where the information is going and the date and that the revocation of the consent is, and be sure that we abide by that.
How close are you? Well, first, before that question, your providers in your authorization and disclosure, can the providers share information between each themselves and another provider on the consent, or does it have to go through the public health?
No, the whole. Oh, I'm sorry. I apologize. I'll shut up, Gary. That's yours. For us, anyone that is listed has that ability to exchange.
Okay.
Yeah, for our universal release, it was really intended for communication across systems, and so that's why we developed the authorization that was specific to our system as a part of that handout number 6, in order to exchange information between our substance use providers within our network.
Well, we're at the end of.
Liz, can I just thought of something. What we didn't talk about, and this is maybe a whole nother seminar, is the release for juveniles, the minor consent release.
Right.
We
did not.
And that's very, but again, with treatment courts and MDTs, that is a whole nother kettle of worms that at some point we should talk about, I think.
I agree, and hopefully it's in the context of adolescent youth treatment guidelines as they unfold. And it's a great topic for next steps. We will close today. I want to thank everyone for their participation. This is wonderful information and materials and a collaborative learning process. And several questions came in. I just want to clarify. These, as Bruce mentioned, are there for you to use and share. The process, Santa Clara County's legal counsel signing off on it doesn't give you the permission to use Santa Clara in terms of your county, but you can use it and take it to your county council and have them review it for your county process and utilize it. I think that the questions that are coming in are very thoughtful and very specific, coming from many of the counties, and many of the answers lie in your policy and procedure and practice guidelines, Bruce, and I'm sure the same will be true as you develop and operationalize your practices in LA County. So I think this group would be very anxious to receive the 3P, the policy, procedure, and practice guidelines for LA. I would encourage the sharing of these documents, and if we can get them made available to us, we will distribute them to everyone throughout the state. I think that there's another document that I want to draw everyone's attention to. There's so much going on. It's very overwhelming, but with the sharing of information and collaborative learning, there's just we don't need to reinvent the wheels. There's a very good report by the California Healthcare Foundation that I will also send out. It was posted in 2015. It's called Fine Print: Rules for Exchanging Behavioral Health Information in California. The reason I draw your attention to it is the new rule will tweak some of the 42 CFR application, but it's a very good analysis and presentation related to HIPAA, 42 CFR, and the Landerman-Dietrich Short Act and how they interface. So I will send that out as a attachment to this presentation. We will send out the PowerPoint, we will send out the recordings, we will try to answer questions if they are not answered inside of the policy and procedure, and we will send out the fine print report from California Healthcare Foundation. The forum, the DMC, I will close with a note that the DMC forum, waiver forum, is supported by the Blue Shield California Foundation. It's a learning collaborative. This is our second webinar, and we are doing this for consideration of time and penetration of information throughout California. Give us your feedback on the webinar and the webinar format. Give us feedback on topics that you would like to hear about. The list is very long, but we can do this and bring in the individuals who have lessons learned and who have explored these areas for us. We do have a webinar, a very exciting webinar coming up on February 2nd, again at 9 o'clock in the morning, and we have invited the MCO, the Managed Care Organization that manages Philadelphia's Medicaid Behavioral Health Services, the Executive Director, and a representative of the Pennsylvania Office of Addiction to talk about and present the landscape of their experience implementing the MCO approach to Medicaid behavioral health services in Pennsylvania, which is a county-run system. So I think there are lessons learned there. Please watch for, we'll be sending out a notice, watch for the notice and register for that webinar. I really appreciate your participation today. Panelists, you are superb and wonderful sharing of information. I'm sure that this will assist many, many counties in the work that they're doing. Thank you all, and thank you to the staff of CIBHS.
Thank you.